Hello everyone, I am Nahid Rhiannon. I'm one of the geriatricians, assistant professor in the Division of Geriatrics and Palliative Medicine at UT Health. We will be talking about fall as a geriatric syndrome. Learning objectives. After this presentation, the attendees will be able to recognize fall as a geriatric syndrome. Attendees will be able to identify risk of fall in the elderly associated with multi-system changes due to aging. And attendees will be knowledgeable about assessment and management strategies for fall in ambulatory practice. So what is fall? Fall is an event that results in a person inadvertently coming to rest on the ground or lower level with or without loss of consciousness or injury. And we have to also exclude falls that happens after a patient has a seizure or stroke. Those are not truly the fall as a geriatric syndrome because they have this underlying cause. So why is fall a geriatric syndrome? What is a geriatric syndrome? Geriatric syndrome is the health problems that involves more than one cause, meaning it happens because of more than one causes, and multiple body parts and systems are involved, and these usually happen because of the consequences of aging, the changes that take place with aging in our body. There are multiple age-related factors that are contributing to fall. For example, we have decreased strength, we have impaired balance. Our sensory and cognitive functions impairs as we get older. So there are multiple causes, and the consequences involve multiple systems, including gait, so mostly musculoskeletal and neurological. We have impaired balance, and then we have fracture and encephalopathy from inflammation in the brain. Intracranial hemorrhage can happen, limitations with our activities of daily living, and of course all of these cause decreased mobility. So fall is a geriatric syndrome, and it is a big problem in our elderly as we have these changes that take place with aging in our body. And as I told you, fall is an important public health problem in the elderly, and look at the prevalence. It's very high. So patients who are, or community dwelling people actually, are older community dwelling adults who are more than 65 years of age, the prevalence of fall among them are about a little more than 30%. And when it's more than 85 years of age, look how the prevalence goes high. It's about 50% of them will have a fall. So that's pretty high. So let's talk about what happens with the fall. What happens when someone falls and what's his relationship with mortality? So impact of fall and mortality. Unintentional injuries, for example, trauma, is the 5th leading cause of death for people who are between the age of 65 and 84 years. And 70% of accidental deaths in people who are more than 75 years of age are because of fall. So that's really a big problem. And multiple falls take place in more than half of our elderly population who are more than 65 years of age. So that's very common. So, 1 out of 2 people will have had multiple falls in their life when they're more than 65 years of age. And falls are the leading cause of accidental death in an older adult. So that is a big public health problem, and we need to be able to address it to prevent, because when it takes place, a lot of things happens. So 10 to 15% of fall causes serious injuries in older adults. And 75% of those serious injuries actually cause fractures. And of course, mortality due to the complications from the consequences of fall is what makes it even worse because of its related injuries like fractures, intracranial hemorrhage, immobility, disability, and all of these have a huge impact on our healthcare cost, on the quality of life the patients are going to have after a fall, and of course the caregivers and the whole family and society. So fracture is a big part of the consequences of fall. and its association with mortality also has a big impact on older people's life. So let's talk about fall fracture and mortality. It's mostly the fragility fractures that we see that occurs in older patients after a fall. Most fragility fractures happen because of the age-related bone loss that we have. So as we get older, we lose bone, we develop osteoporosis. And so when we fall, even without a high-impact trauma, like we're falling from a standing height or from a wheelchair, we do fracture our bones. Specifically, hip fractures are really bad and devastating, and we do hear about it a lot. But see, only 1 to 2% of the falls cause hip fracture. But we do hear about hip fractures a lot. And guess why? 95% of the hip fractures are due to falling. And 75% of them happen in women, so you will see that this is a common problem in older women, but it doesn't mean it doesn't happen in men. They also have this problem. And 20% mortality within a year after a hip fracture. And I'll talk about a case at the end of our presentation, how it spirals down after a fall and a hip fracture in a person's quality of life. So it's really important, and that's why we hear about it so much. And also, if one survives the hip fracture, guess what? About 50% of them will never walk without assistance. So what happens? If someone has a hip fracture, they were living at home independently. After this event, they will not be able to live there anymore. They will have to change, either go to an assisted living, nursing home. That changes the whole scenario for not only that person, but also for the family members and the healthcare providers in the healthcare system. And about 25% of them will require a long-term care. So that makes a big change in the person's life who just had a hip fracture due to a fall. And Medicare in the United States spent about $2.9 billion in 1991 in hip fracture related care. So that's a huge healthcare cost as well. So why do older persons fall? Multiple and interacting risk factors. As I mentioned briefly earlier, that we have physiological changes taking place in our body with aging. Although it varies by person to person, or not everybody changes at the same speed or at the same time of their life, but it happens in almost everybody who gets to be old. Older than 65 years of age, that's what we mean here with aging and elderly. So the changes due to aging are pretty much gait and balance disorder, which impairs our walking ability, mobility, which then causes functional impairment. Visual and hearing deficits, so it's really difficult to find your way well and be out of the hazards if you can't hear well or if you can't see well. And of course, if we have cognitive impairments, then it's hard to know what is safe and what is not safe and find your way properly so that you don't fall with all the other things that are going on. Then comes the environmental risk factors, and we'll talk about it in a minute. And then iatrogenic, what we introduce to the patients as a healthcare worker. For example, we prescribe medications, and some of them are inappropriate for older patients to use. Some of them have side effects that can cause these changes that otherwise would have happened with age-related changes, and that can cause a fall. So as we just talked about the risk factors for fall, look at what happens in people who are without any risk factors and who have multiple risk factors. So as the number of risk factors go higher, they have higher risk of fall. So if you look at this graph on the left side, these are people who are older than 65 years of age, and if they do not have any known risk factor of fall, the prevalence of fall in them will be about 8 to 12%. And those who have more than three or more risk factors will have a prevalence of fall between 65 and 100%. That's a huge jump in prevalence with the number of risk factors. So let's talk about the factors that I told you about, the changes that happen with age, environmental and the iatrogenic factors that are important factors that contribute to fall. So changes with age that causes fall. We have decreased reflexes. Think about how many times we have to turn right away. We have to kind of prevent something on an urgent basis. So with the decreased reflex, there is a decreased reaction time in a response to a sudden movement. So if somebody pushed me from the back or I stumble on something, then the reaction time is less and I can't really stop myself quickly enough to prevent a fall. So there is decreased ability to balance and control my body movement, so there is a fall. Decreased vision, and the common age-related eye problems or vision problems that we have are glaucoma, cataract, macular degeneration. And then they will decrease alertness because you will not be able to, and with these different types of changes, as you know, our vision field changes. And so it's really difficult to view everything that otherwise we are able to see and watch and be alert of what's coming on or what is out there so that I can protect myself. But it doesn't happen with vision loss or decreased vision. And so with decreased alertness, there is increased risk of fall. And with decreased hearing, well, there is decreased alertness as well. So there may be somebody or something coming near to you or approaching you, or you are approaching that. So if you have both vision and hearing loss, or even hearing loss, and you're walking towards something that's making noise, you will not be able to hear. And of course, that decreases your alertness in the environment, and it increases chance of falling. So decreased muscle mass and strength, which is also important for gait and balance. So we lose muscle mass as we get older, and it decreases strength of the muscle as well, which then will be hard to keep the balance and increase weakness. So you will see these in patients who come to your clinic or come to the hospital. You'll see how much longer an older patient takes to stand up from a chair, how much help they need. Like they will try to find something to support their weight on, to support their balance on when they're moving around. When they walk around, they will try to like grab on the wall or the furnitures. So those are because of this decreased balance and weaknesses that happen, also associated with muscle mass loss and decreased strength. So that is an increased risk of fall. And with decreased cognitive function, of course, we don't understand what is safe, decreased alertness, and it increases risk of fall. Orthostatic hypotension, it can happen just because of age-related changes in your vascular system, or it can also happen with medications that can decrease your blood pressure as you stand up from sitting position or you try to get up from bed. And so there is decreased blood flow in your brain, and it causes dizziness, and of course, that's when we fall. So these are some of the examples of what happens with age-related changes in a person, and that can contribute to fall. So let's talk about the environmental changes and the health situations that can cause a fall. So our living situations, as we get older, like I said, someone, if they fall, it's really difficult for them, and then they have a disability, it's really difficult for them to live by themselves anymore. But then if they do live alone, and there is no immediate help available, what happens when you fall? Oftentimes you will see some ads on TV, an older person has fallen and they will be on the floor sometimes more than 12 hours because they don't know how to get help. They are not falling right beside a telephone so that they could pick up and call. There is nobody in the house so that they could scream and somebody could hear. Sometimes their children, sometimes their neighbor, sometimes someone, their caretaker will come next day and find them on the floor, which can happen. And why did that person fall? Maybe because of the age-related changes that I have already described, but then there could be clutters. For example, furnitures, cords, boxes, rugs, pets. It's difficult for someone with some disability or these age-related changes to clean up their house always, to keep things in place. And if they have visual and hearing loss or impairment, this will be even worse. No support when ambulating. So like I was telling you, if they have decreased balance, they're going to be walking around and trying to reach for support on furnitures or walls. So sometimes to equip home safety or where they live, we have handrails on the walls so that they can hold on to them and walk to make it safer. But if they don't have it, then it becomes difficult for them, mostly the people with the balance and gait impairment. Defective footwear. So, they're comfortable and good shoes with good balance, that will not cause pain, that will not just tip you over just because. Those are very important. Use of ambulatory assistive devices. For example, if someone has decreased balance and impairment, then they need a support to walk. So in some people it will be a cane, but in some people they need a walker because they really need a better support system. And sometimes it's difficult for patients to walk with those because it's kind of a stigma. People see you walking with that, so they will know that you disability It's really hard for the person who is needing that help, and everybody looks at you. So to avoid that, people sometimes, even if they need it, they're not using it, even if they have it. So it's an important question to ask a patient when they come to visit you. If they need it, and if they're not using it, that's a risk factor. But sometimes if they have it and they don't know how to use it, is also a risk factor. And uneven walking surfaces. Sometimes the neighborhood sidewalks are not even, and if they have to walk with a cane or a walker, it becomes difficult for an older person. If they have decreased visual impairment, they will not be able to see where they have to step very gently, and they are not able to do that, so they will fall. And the chronic illnesses doesn't help. Most of our older people will have some chronic illnesses or medication side effects that actually impairs their circulation, decreases their sensation in their foot, like diabetic neuropathy, or they will have pain from arthritis. They will have decreased strength from the decreased muscle mass, as I told you, and impaired functional status that can cause fall. And with the environment and these health factors together, it just increases the risk of fall more. Most elderly patients who will be coming to see you in the clinic will probably have urinary incontinence, and it's sometimes in both men and women, mostly in women. And the patients may not tell you that they have urinary incontinence. Oftentimes we have to ask them because it's very embarrassing for them, but it's a very common problem which can cause increased risk of fall. And how does that happen? So first of all, what's the prevalence of this problem? So 23% of the people who are between the age of 60 to 79 years have this problem. And as they get older, the problem becomes more common. So 32% of those who are 80 years and older, and 58% in those who live in a nursing home. So what's different in the nursing home population? They are more disabled. They need total care. They have decreased mobility most likely, or they are just cognitively impaired. They cannot take care of themselves. So in those patients, it's even worse. And like I said, it varies by gender, but it's most common in women. And it varies by ethnicity. The non-Hispanic whites have the most common in the non-Hispanic whites, then the Hispanics, and then the African Americans. And why do people fall with incontinence? What happens is when they have an impulse to void, they don't want to have an accident. So to avoid the accident, to urinate on themselves, what they do is they rush to the bathroom to void. For example, if someone is getting up from bed in the middle of the night, they may have a nightlight, but it takes a while to get adjusted. And if the bathroom is a little bit far from you, then you have to run to the bathroom through probably furnitures and whatever is on the way, like a rug that you can sleep on and then fall. So this interaction between the environment and this health problem causes increased risk of fall. And there are some reversible causes of incontinence that we need to think about when a patient comes with this problem, because that can most of the time be fixed. For example, urinary tract infection, atrophic vaginitis, or urethritis. These can be helped. These can be improved with treatment. After surgery, a post-prostatectomy and stool impaction, believe it or not, constipation can cause urinary incontinence. Medications like diuretics, if they're taking it at the time when they'll go to bed, they will invariably have to wake up in the middle of the night and go to the restroom. That will make their incontinence even worse. Or increased urine production in certain metabolic diseases like diabetes, other health problems like excessive fluid intake, volume overload with congestive heart failure, edema, venous insufficiency. Those are the health problems that will increase urine production. So if someone has incontinence mild, that will make it worse, or they may develop urinary incontinence. So we have to look at the underlying causes and try to help them by treating those diseases so that at least some of the factors can be relieved. So the polypharmacy, the iatrogenic cause that increases risk of fall, and it's because polypharmacy and adverse drug reactions. So the definition of polypharmacy varies a little bit. Most literature says that if someone an older patient, which we refer to as 65-year-old or older, is on more than 4 medications for about 3 months consecutively, they have to take it at least for 3 months. But guess what? When we admit a patient to the hospital, on an average, we prescribe 8 medications to each patient. So we ourselves are causing this problem. But If you go over the problems that they most of the time come with, there's no way they can have less than 8 during the acute phase of their treatment in the hospital. But even if they go home, of our elderly patients have been on more than 4 medications, so they are at risk of fall because of the drug-drug interaction between those medications, or even the drug side effects, the adverse drug reactions. And sometimes there's no way to avoid these medications because they have the other health problems that you need to. So we need to pay attention to that. And the increased risk of fall due to the increased risk of adverse drug reaction actually can cause hospitalization, and I'll talk about it in a few seconds. So the polypharmacy and use of inappropriate medication both can increase the risk of adverse drug reaction due to the side effects and drug-drug interaction, as I told you. And the most common ones that we see in the hospital usually when the patients come in are the anticholinergic medication like the benzodiazepines. They can cause confusion, sedation, and these can cause fall. Muscle relaxant or antispasmodics like cyclobenzaprine or oxybutynin. These are also medications that can cause sedation, weakness, confusion, and all of them can increase the risk of fall. Alpha agonists like clonidine, which we use for treating blood pressure in hypertensive patients, but in the elderly it can also cause orthostatic hypotension, and we talked about it that orthostatic hypotension is a cause of risk of fall. And as I told you from the drug reactions, about 30 to 45% of the hospital admissions occurs due to adverse drug reactions. And most of them are because the patient was taking an inappropriate medication. And they come in with a chief complaint most of the time of altered mental status or confusion that caused the fall, or the patient will come in with fall and you will see that they are altered. So we talked about the different types of risk of fall, age-related changes, environmental factors, interaction between the environmental and the health factors, and the iatrogenic factor that we cause, the healthcare professionals, by prescribing medications and the side effects from the medications that can cause fall. So what happens when someone falls? Like I said, they will come with the fall and they will be confused. But what does it really mean? We need to find out then what's going on. A fall can just be a tip of the iceberg because, as I told you, they will come in with the chief complaint of altered mental status and confusion, but actually what was the cause of the fall? See, it could mean an acute illness or underlying systemic process. It could mean a cerebrovascular accident, acute coronary syndrome, or a myocardial infarction, metabolic process with some underlying diseases that is worsening like diabetes, infection, electrolyte imbalance as indicated by their history and lab. When we do physical exam and when we do a laboratory test, then we will find out. And of course, there could be environmental hazards that we can find out from histories, from their home situation. And when we do medication reconciliation, we will find out what type of medications they're on and if it is a problem from the side effects of the medications. So really, that fall is the tip of the iceberg when we need to investigate what's going on behind it so that we can help the patients to prevent another fall in the future. So we just talked about how fall is tip of the iceberg of multiple problems that may have caused or contributed to the fall. So when an elderly person falls, it's really a high alert because we don't know what's going on underneath, and we have to investigate and really find out what is or what are the causes of fall that we need to take care of. So fall in the elderly can cause a hospital admission. Certainly, like I said, they'll come in with altered mental status most of the time. The family will only, or the caretaker or whoever is bringing the patient will only be able to tell you the patient fell and now they're confused or altered mental status. A full history and physical exam is important to investigate this. And also, even if the patient did not fall right now and they did not come to the hospital, but they are visiting you in the clinic and you ask them if they had fallen, because sometimes they will not tell you if they have had falls. They forget or they think it's normal part of older life. But if you ask them and if they told you that they had fall in the past, then you need to find out what is their baseline functional status. So we need to investigate that so that we know if anything changes in the future that can also increase the risk of fall. We need to do medication reconciliation because we talked about how polypharmacy or inappropriate medication use can increase the risk of adverse drug reactions, which can then cause fall increased hospitalization, increased immobility, and disability. So, and the social and environmental factors, we have to think about this. Home safety, if the patient is living alone, do they have a way to call for help, life alert, or are they living with someone when they cannot live by themselves anymore? And if the environment is organized safe enough so that they can walk around safely and they have good assistive devices if they need to. Physical therapy, if they have improved balance and gait to improve the balance. And safe discharge, so that even if it is from the clinic or the hospital, the patient has a good way to return home or wherever they live, assisted living, nursing home, independent living, or senior living, and that it is safe to go to that place. If there is someone there to look after them, and if they don't, then we know how to provide or how to organize that care for them 24/7 if they need to. So as we continue, and when a patient comes to you, to the clinic, or if you just talk to them, there are some screening tools that are recommended for assessing risk of fall in the elderly. And the Center for Disease Control, the CDC, actually has this questionnaire, which is called STEADI, STEADI, and you can Google this. It's a 10-item questionnaire for community dwelling people, whether they have had a fall in the past or not. And this, out of this 10, if the score is more than 4 or more, then it is recommended that that person should talk to their healthcare provider about the questions that put them at the risk of fall. So by the healthcare experts during the hospital or the clinic visit, you need to think about the chief complaints, why they came. Like I said, if they had a fall, or if they had a dizziness, or nothing related to fall, but you ask them, and signs observed by the healthcare providers. For example, I was telling you that if a patient is walking in, or you ask them to walk a little bit, or you ask them to get up from the chair to check the ability to lift themselves and walk without assistance, then you will see that they are trying to show signs that tells you, oh my God, their balance is really not good and they need improvement. So one important thing among all of these that we're talking about is to ask them if they had a fall in the past 6 to 12 months. Because like I said, the patients do not sometimes report this because they just somehow think it's part of life or it was an accident. They cannot think that there are so many other factors that can be causing this and that can be sometimes prevented, and that would prevent many disastrous consequences. So continuing to screen patients and assessing patients for a risk of fall, so you have to ask them, did you have a fall or not? Yes or no? And recurring falls, how many falls did you have in the past year? 2, 3, once every month? Some patients will tell you when you ask them, or their caregiver or their family member will tell you, no, they often fall like 5 or 6 times a month. So that's a red flag right there. And then you evaluate, and you evaluate by, like I said, you have to do a full history and physical exam, medication reconciliation, you check their vision, gait and balance, lower limb joints for mobility. Of course, the upper limbs are also important. Neurological, if they have any weakness or a deficit, neurodeficit from a previous stroke. Cardiovascular, if they have congestive heart failure, do they have disability to with shortness of breath because they can't move around much, so it limits them, and so they are not moving around at home and losing their strength and balance even farther. And some of the factors that we need to pay special attention to when we are finding out the underlying causes that are contributing to falls. Well, accidents, are they having what they call accidents at home? Are they falling, and then you will see if you do a home safety evaluation, they have multiple pets, it's really not clean, and multiple hazards because there are furnitures all around, so those are environmental hazards. And then you have to find out gait and balance disorder, dizziness and vertigo. We talked about syncope is when a patient was passing out when they didn't want to, they were just walking or sitting down. Hypotension, dementia, visual or hearing disorders, and loss of consciousness. All of these things can indicate something else is going on, or that this is only the factor and we need to take care of that. When we are assessing gait, we need to think about some of the factors that are key in gait assessment. Stride, the way we walk, the length of one, when we put our foot forward, that should be at least twice of our foot length. The stance widens with gait pathology. So if it is wider, they have some kind of pathology there. Posture, whether it's upright, whether it's kyphotic, or whether it's stooped over. So there could be some musculoskeletal disability, or they may have had a fracture. Arm swing, whether they're swinging their arms, and we do that normally, which is symmetrical, but it can be asymmetrical or no arm swing because of some other neurodegenerative diseases. Balance, especially with rising, turning. So when they're rising, if they're falling or feeling dizzy, or when they're turning. Speed, how fast they're walking, and did it really decrease since the last time you have seen the patient, or if the patient is reporting in the past year or so. Most gait disorders are associated with an underlying pathology or disease process. Start? A few different types of gaits that are common in our older patients, as described by Dr. McDonald. Ataxic gait, unsteady, uncoordinated wide-based gait with feet thrown outward. Antalgic gait is a painful limping gait, when you will see a patient is limping and the feature will tell you that they're trying to avoid bearing weight on one of the joints, and it can happen after a fracture, after surgery, after like if the patient has arthritis. An apraxic gait is a loss of ability to carry out familiar purposeful movements, and that happens in the absence of paralysis or other motor or sensory impairment. Fascinating gait is flexed trunk, legs flexed stiffly at the knees and the hips, and no arm swing. As I told you, that there are some health problems that can cause that. And very short steps that becomes faster over time, and these are mostly seen in the Parkinson's disease and other neurologic disorders, and these are risk of fall. So commonly we use the functional gait and balance assessment in the clinic mostly, or even in the hospital. Clinically very easily done and not much time consuming. It's called timed up and go. Then we see the mobility and ask about the patient can complete their ADLs, which is activities of daily living. For example, bathing, dressing, transferring, and if they are continent or not. So we ask the patient for the timed up and go test to stand up from a chair, walk 3 meters, turn around and walk back and sit down. And you observe them and you time them. If they were able to do this in less than 10 seconds, they're at very low risk. If they took about 11 to 19 seconds to do this, they're at low to moderate risk of fall. And if it was between 20 and 29 seconds, it's moderate to high risk of fall. And if it is more than 30, then they have impaired mobility and is at high risk of falling, so we really need to intervene. There is no set guidelines for laboratory or radiologic testing. It varies by the type of complaints the patients have or the health problems, but mostly you will rule out any infection. So you'll check CBC, complete blood count, urine analysis, blood culture, chest x-ray for pneumonia, to see if that is impairing their ability to function and become mobile. Metabolic, you want to check thyroid function, electrolytes, glucose, calcium, vitamin B and vitamin D. Although there is controversy and they haven't found a causal relationship yet, lower vitamin D or insufficiency and deficiency of vitamin D is associated with high risk of fall. Drug levels and urine toxicology, like if they have been on anticonvulsants or illicit drug use. Brain imaging and cardiac evaluation can tell you if there's any neurological or cardiovascular diseases going on as underlying causes of fall, and of course other joint x-rays as needed. If they have pain or if you know there is swelling or other signs or symptoms, tell you to do that. So what do we do when we find out all of these, that we do get the history, the patient came in with fall or did not come with fall, but you find out that they have had falls in the past and they are at high risk. Now from your assessment, that's what you found out. So number one, like we learned, that there are multiple and interacting underlying causes that cause the fall. We have to treat the underlying cause and help the patient and family understand those risk factors and that association between the risk factor and the fall, so that they understand why fall happens and what happens when a fall takes place, the consequences that can happen, how that will change their life, how that can change the quality of life, and address the fear of fall. Fear of fall is an important risk of fall. because then you will not move around, yet decrease more strength and muscle mass, impairs your balance and gait more, and there is higher risk of fall. And most of the time it is the balance and gait that needs to be improved, and that can be done most of the time with physical therapy and occupational therapy. So we need to address that and inquire about fall and screen during every encounter you have with a patient, no matter whether it's in the hospital or clinic. Mostly in the clinic you get this opportunity to do that more, but every opportunity we have for an encounter with the patient, it is important that we ask about fall, because it may not be voluntarily given to you. Some of the things we can do is ask for risk of falls. That is urinary incontinence, as I told you. We can screen by these 2 questions that are suggested by the American Academy of Family Physicians. Do you ever lose urine when you don't want to? Or have you lost urine at least 6 separate days? And if they say yes, then they're at high risk, and then you have to go investigate in detail even further. And it is most likely stress incontinence if they said yes to the question, do you ever lose urine when you cough, sneeze, or exercise, lift, or laugh? And if they say yes, then it's most likely stress. And no matter what, for the treatment, it is important to think about the bladder hygiene. So you tell them to go to the restroom even if they didn't need to, even if they did not have the urge to, but to keep their bladder empty and avoid this kind of rush and emergencies, which will avoid falls, to go to the restroom every couple of hours, or avoid drinking full glass of water at least 2 hours before you will go to bed. And then empty your bladder before going to bed. Have the bedroom light up, so that have a night light at night, so that you don't have to wake up in the dark. And if needed, send them to urology, so that some underlying factors that can be fixed by the urologist, they can do that, or even to diagnose problems. Medications, there are some medications that are prescribed to patients, but most of them are anticholinergic, and so they increases risk of fall, and as we discussed earlier. And oftentimes you'll see the patients will be coming in diapers, and they're using pads, or they still have the problem, and then they're taking this. So this is a good point to discuss with your patients, to try to see if you can discontinue those medications. Orthostatic hypotension, either a decrease in the systolic blood pressure 20 or more and diastolic 10 or more when they're standing up from sitting position or they're getting up from bed. And heart rate may or may not be changed, because a lot of patients will have a pacemaker. But if you have this and patients are feeling dizzy, you need to do something about it. And sometimes it cannot be fixed. So some behavioral training can be given, like sit down after getting up from bed for a second. Don't move fast. Start moving slow. Use your assistive devices. Call for assistance, that we do in the hospital, always for the patient to call for help. Decrease dose sometimes of the medications that is causing the blood pressure to be too low, or even discontinue. Substitute medication for a better one, which can decrease the problem. Sometimes the circulation is not good, so suggest them to wear pressure stockings, so the circulation from the lower limbs can be better improved. Medications like fludrocortisone or midodrine are sometimes used in extreme cases, but it is really a specialty medication, and I would recommend consulting specialists before prescribing anything like this. And some such studies suggested caffeinated coffee, but I'm not sure how. This may not be appropriate for all of our elderlies. And how do we prevent? Of course, we target the interventions to risk factors that we discussed. And we do this with a goal to minimize risk of falling without compromising mobility and functional independence, which is sometimes difficult. But we do prioritize fall prevention program. So when in your clinic or wherever you're practicing, and even in community education, you need to prioritize this, so focus on this. Establish a tailored exercise program. Tailored meaning it is individually tailored. So someone may be able to walk around and do exercise, and some patients are not even able to get up from the chair without help. So for them, this exercise needs to be tailored towards their need and what they're able to do, and to set a practical goal of how far they can advance and improve. Tai Chi classes, physical therapy, these are known ways to improve gait and balance. Sometimes some studies say offer hip protectors to all persons at high risk, and this is controversial again of how much they have improved the fracture risk with the fall, but this can be available in this website. I wanted to discuss a case with you guys. This is a real case. This was a 76-year-old, very pleasant woman who had a mild limp on the left side due to a residual deficit from a stroke that she had about 10 years ago from when I saw her, and she had osteoporosis. And she was a very lively woman who always wanted to be as functional and active as possible. She was going dancing once a week with her daughter and friends. That's how active she wanted to be, even with her little bit of disability. So one night she fell when she was trying to get into the truck when she was going home after her dance one night when it was raining. And she slipped and she fell and she broke her right hip. And then I saw her in the hospital. She had a surgery to fix her hip fracture and she got rehab. She went to a skilled nursing facility outside in the community. From there she went to home and actually came back to the hospital because of infection. And then she went back to skilled nursing facility. She was not at home for probably more than about 2 months, most likely, at the most. And then she went back to the skilled nursing facility after the hospitalization. So she went back to home from there, but came back to the hospital with stage 4 decubitus ulcer, poor nutrition, and very depressed. And this lady has not been a depressed person, as I told you before. But this disability, pain, and immobility from the fracture, the consequences of the fall and then the fracture, has now caused all of this. She developed a stage 4 decubitus ulcer. She has become depressed, didn't want to eat, became malnourished, which is not helping to heal her ulcer. And she was discharged home with hospice during her last admission into the hospital. And she died 4 months after the discharge. And the time since the first fall and her death was about 18 months. So this is how the life can change after a fall in an older person, which, like I said, is not just a change in the patient's life quality, is the family's life, is the society's change, and not to mention our healthcare cost. So by preventing a fall, we can prevent a lot. We can improve quality of life in our older patients. And we need to just understand that we have to assess the fall risk, talk about this to our patients, even if they don't volunteer about it, and then find out the risk factors, find out the underlying cause, and treat them and prevent them. So the take-home message from my presentation, I hope that all of you will get, is fall may be the tip of the iceberg. You need to investigate why it's happening and find out what's the underlying cause or causes. An interdisciplinary approach is the most effective way to prevent falls in the elderly, because we need to know about the biological changes that took place, physiological changes that a geriatricians can help with, the environmental factors, the home safety evaluations with the social workers, with the physical therapists, occupational therapists, nurse practitioners, mid-level care providers, and the nurses, and the pharmacists who can help us with the medications. So it's really an interdisciplinary or interprofessional approach that we need to always think about and provide for our patients who are at risk of fall, and to prevent a fall and treat them. Thank you.